Perfect. You guys quiet down over there. All right, so good morning, everyone. Thank you for joining us, Head and Neck Live. Today is May 3rd, 2023. We're still waiting for spring to come, but it'll come very soon, I think. So this morning we have our first resident to present to us. Her name is Dr. Emily Zhang. She's one of our third-year residents here at Cleveland Clinic Otolaryngology Head and Neck Surgery Residency Program. She comes from Indiana, where she grew up with her family, including her younger sister. She then completed undergraduate studies in neuroscience and Chinese at Indiana University. And then she came to join here at the Lerner School College of Medicine, where she became interested in head and neck surgery and joined our residency. And so we're very lucky to have matched her here, and she's done an amazing job in the last 3 years. And today she will be talking to us about a very rare disease topic in head and neck cancer on the topic of minor salivary gland malignancies. During her free time, she likes to hang out with her husband and her friends, and she likes to play cards, board games, and is attempting how to learn tennis. Is that right? Who's teaching you? That means you're not working hard enough.
That's why it's attempting, not succeeding.
So yeah, we're very proud of you. Thank you for presenting today, and we're very excited to learn about what you did during your research time. So thank you.
Thanks, Dr. Koo. I just want to take a moment to thank Dr. Malek Bouzaher for also giving me this time slot to present. Just kidding, love you. So today I'm going to be talking about minor salivary gland carcinoma. Hopefully it'll be interesting, and I'll talk about some things. I feel like minor salivary gland is not covered as much, and it's a little more rare. So these are the things that I hopefully will cover, go over some basics. What are the challenges in studying minor salivary gland cancer? What are the major studies? Cover the epidemiology and histologies, significance of grade, the treatment, survival and prognostic factors, what are rates of cervical nodal metastases, and then finally, what are the data here at Cleveland Clinic? So let's start with a case. So a 55-year-old female presents to your clinic with a 5-month history of a 2.5 centimeter painful mass at the hard palate. So you suspect maybe it's a minor salivary gland cancer. So let's just talk a little bit about the physiology. So you have anywhere from 500 to 1,000 minor salivary glands, and they're actually distributed all throughout the mucosal membranes of your aerodigestive tract. So not just oral cavity, which is what we think of classically, but also oral pharynx, the sinuses, the nasopharynx, the hypopharynx, and even the larynx and trachea. Most of them, 90% of them, are in the oral cavity and oral pharynx. They produce about 10% of the saliva, so nowhere as much as the parotid. And the saliva that they produce tends to be more mucinous and viscous. And in terms of their structure, they have acinine with a short ductal system and no capsule. And obviously, they don't have the same structure and organization as the major salivary glands. So what about carcinomas in general, which I'm going to abbreviate because it's a very long term. So they comprise 10 to 15% of all salivary carcinomas. And the classic teaching is up to 80% of it is malignant versus 20% in the parotid. I think more recent data shows probably somewhere closer to 40 to 60% end up being malignant, but it's very rare. So the incidence, the annual incidence is 0.16 to 0.4 per 100,000. And if we look at the distribution of primary tumor sites, on the left here, you can see the distribution. Most of it is presenting in the oral cavity, no surprise, because 90% of the minor salivary glands are in the oral cavity. And then after that, oral pharynx, then nasal cavity, paranasal, and then larynx and hypopharynx are lower incidence. And then if you divide up the subsites of the oral cavity, on the right, you can see that most often they will present in the palate, which is what we see in our sample case here. So what are some of the challenges in studying minor salivary gland tumors? Why are there so few studies on it? And what are the major studies just looking at that? So number one, as we talked about, it's very rare. Number two, it's heterogeneous. So there's more than 20 different kinds of malignancies, histopathologies that can present in this area. The WHO classification updated in 2017, and there's just a whole list of things that can grow in that area. And then, as we also already talked about, it can present in so many different anatomic sites. So each site kind of has a different type of treatment and surgery as well. So studies often will combine major and minor salivary gland tumors because they do have similar pathologies, or they'll categorize by anatomic site, or they'll categorize by histologic type. So you have a vast array of studies that combine major and minor, combine different sites, combine different histologies. So it's heterogeneous and difficult to compare between studies. But if you try to make it a homogeneous study, then you run into the issue of having very low N numbers. So it's a bit of a challenge to study because of that. So what is out there in terms of the biggest studies that are only looking at minor salivary gland tumors? So these are sort of some of the biggest ones. You can see they're often retrospective, looking over a long time period, ranging anywhere from 450 to even 12,000. But the larger numbers are all database-based studies, right, where you can't really control the variables that you're looking at. So we have a couple of SEER database studies, one from the NCDB, and then there is a retrospective study out of MSK, and then some studies from other countries as well. And then most of these are all just covering minor salivary gland carcinomas, but you will see that the NCDB study is actually only looking at mucoepidermoid cancer in the oral cavity, oropharynx. So it is still minor salivary gland, but it's only looking at that specific histology. So what are the different things that can present in this area, and what's the epidemiology of it? So there's maybe a slight predilection for females, tends to present older, as many cancers do in the 5th to 6th decades. Female sex has actually been associated with a better prognosis, so higher overall survival and disease-specific survival. And then men tend to have a higher odds ratio having regional metastases. Age, as with many things, is a worse prognostic factor. It's usually associated with a higher risk of malignancy. And then this is just demonstrating the survival difference between males and females here. But I would like to point out that if you look at, let me see if I can pull up my pointer. If you look at 5 years, the survival there is actually pretty similar for men and women. But as you get further out to 10 years, that's when you start to see the lower survival for men. So what are all the things that can present in minor salivary glands? This is not even a comprehensive list, but there are some things that tend to present more often in minor salivary glands, some more often in major, and some in both. And I won't go over each histology here, but I've bolded the ones that are most relevant or most common. So those big three are mucoepidermoid carcinoma, which we know is the most common one, parotids, adenoid cystic carcinoma, which is classically the most common one in the submandibular gland or the minor salivary glands, and then also various types of adenocarcinoma, including polymorphous adenocarcinoma. So if we look at the distribution, what are the most common ones? Classically, we think of adenoid cystic carcinoma. If you look at all these big studies that have been done, they sort of vary in their proportions. And so this study here kind of reviewed all of the different distributions of all three of these histologies from these different studies, including the SEER, the NCDB database, MSK, and South Africa, as well as Brazil. And they averaged them, and they actually found that adenocarcinoma was highest when they grouped all the statistics together. But that is also a little bit complicated, as we'll talk about a little bit later on, because adenocarcinoma can be kind of difficult to differentiate or identify. The other thing to note is that the type of histology also kind of depends on location. So if you look at, this is out of the MSK data. So if you look at the oral cavity and oral pharynx data, you can see that most of that tends to be more mucoepidermoid. And they see that, their reasoning for that is you have more squamous mucosa in the area where mucoepidermoid might arise more, versus more respiratory epithelium that tends to predominate in the sinonasal cavities or the larynx and trachea, where you see actually adenoid cystic tends to be more predominant. So it does also depend on the anatomic site. So just a brief interlude to talk about the confusing world of adenocarcinoma, because you might see this, but so basically in the 80s, they found this entity that they decided to call polymorphous low-grade adenocarcinoma. Polymorphous because it has all these different architecture and appearances on histology. Low-grade because they found that those patients tended to have better outcomes in survival. So they called it PLGA. And then they kind of looked more at the subgroup of patients. Maybe not all of them did really well. So they said, okay, maybe we should stop calling it low grade because there are high grade versions. So now it's called more broadly just polymorphous adenocarcinoma. And you'll see that that changed in the most recent WHO reclassification in 2017. Then to complicate things even further, they also found this entity called cribriform adenocarcinoma of the minor salivary glands. So they originally found this kind of in the base of tongue, usually the lateral base of tongue. They thought maybe it was related to papillary thyroid cancer because it looks histologically similar and it was in the base of tongue. But people were like, well, that should be more midline, not lateral. We don't really know what this is. So maybe it's the minor salivary glands. So, they just described the appearance and called it that. So I don't think it's very clear whether this is a separate entity from polymorphous adenocarcinoma or not. In the new WHO classification, I think these two get combined. But the thing to know is that the CAM-SG tends to have a higher rate of nodal metastases. So as a group, the patients do a little bit differently. But if you ever see patients with, all these words and they get diagnosed with that, that's kind of the background of it. There is still controversy behind that. So what is the significance of grade? I know we talk about grade a lot with salivary gland tumors. So one thing to know about all the different pathologies that can occur in the salivary glands is they have grouping of what we call, more low risk pathologies versus high risk pathologies. So meaning high risk usually tends to mean you want to add some kind of adjuvant treatment in addition to surgical excision, which is still the mainstay of treatment. There are some pathologies that are more classically low risk, for example, actinic cell carcinoma, and then things that are more classically high risk, so carcinosarcoma or mucinous adenocarcinoma. Those patients tend to do poorer overall, so you want to be more aggressive with treatment. The cancer itself is more aggressive. But then there are entities like mucoepidermoid carcinoma that can be low grade or high grade. So that's just kind of something to know, that each histology can be categorized a little bit differently. And then, some histologies also have specific grading schemes. In particular, the ones we already talked about a little bit, adenoid cystic carcinoma, mucoepidermoid carcinoma. So the one we're probably very familiar with this, adenoid cystic, grade 1 is predominantly tubular, grade 2 has maybe some cribriform or solid component, but it's less than 30%. And then 3 is more than 30% solid. That's probably the one that we see and use the most often. The grading scheme on the right is, I haven't seen that used as much, but that's another grading scheme. And then for mucoepidermoid carcinoma, there's actually 3 different grading schemes out there. There's Healy, AFIP, and Brandwein. The specifics of the grading is not important. I think my point here is that there's not exactly a consensus between pathologists, and in particular regarding intermediate grade. Intermediate grade is a little bit of a gray area, but in general, from this paper that I read, AFIP tends to downgrade intermediate grade tumors, whereas the other two tend to upgrade them. So I think, when we want to be more conservative, it's better to use Healy or Brandwein. So in this case, that as example, you take a biopsy of the lesion, which shows adenoid cystic carcinoma, tubular pattern, so grade 1. And then she gets a CT neck with IV contrast that shows no cervical nodal disease. So what do we do? What do we offer her now? So part of the reason why we care so much about grade is it impacts prognosis. So it also dictates a little bit of management. So here you can see the things that we would just want to do surgical excision of the primary site for versus surgery and radiotherapy, at whether or not to do a neck dissection, and then whether or not to use systemic chemotherapy. So usually if we're talking about a low grade tumor, low T stage, T1, T2, and it's a low risk subtype, you can get away with just surgical excision of the primary site. No need to do a neck dissection, granted, given that there's no clinical nodal disease, no need to do adjuvant radiation. Obviously, if you have close or positive margins, you're going to want to add adjuvant radiation. But the other indications would be a high-grade histology, like we discussed. So let's say they have high-grade mucoepidermal carcinoma, or if Our Lady had predominantly cribiform type. And then high-risk histologic subtype, positive occult nodal disease, and a high T stage. In terms of when to do a neck dissection, obviously any clinical nodal disease, you want to do a neck dissection. But if they have no clinical disease, otherwise they're CN0, then if it's high risk or high grade histology, or they have a high T stage, that would be an indication to do that. The role for primary or definitive radiation is limited because the outcomes are not as good. The survival is definitely lower. So, primary radiation treatment is reserved for people who can't tolerate surgery or don't want surgery, but recognizing that it doesn't have as good of an outcome. And then systemic chemotherapy, as you may know, has a pretty limited role in salivary gland tumors. There are some studies that look at systemic chemoradiation for like recurrent or metastatic disease, but otherwise there's not big trials on it, and they haven't found any survival benefit with chemotherapy. So your lady, she undergoes wide local excision of the mass with local tissue rearrangement, and she had no bone involvement, and you did a great job. She had clear surgical margins. So then she undergoes adjuvant radiation. So the point I wanted to make about this case is she was low-grade adenoid cystic carcinoma. But if you look at the ASCO guidelines, if you look at the data on adenoid cystic specifically, you still want to do adjuvant radiation. It is considered a higher risk pathology. So what can we tell her about her chances of survival, the prognostic factors that matter? So this is a nice summary of all the big studies. Again, you can see that 5-year survival varies anywhere from 76 to 86%, pretty good. But if you go out to 10 years, that gets lower. That gets down to 60 to 70%. The things that matter, age, as with many things, we already talked about the role of sex. Obviously, pathology risk group, if we're talking about high risk, they definitely have lower survival. And then, whether they got margin status, their T stage, TNM stage, and then sometimes they've seen anatomic site making a difference. So specifically, nasal sinus minor salivary gland tumors tend to have a lower overall survival. This is a nice paper that put together a nomogram to kind of counsel patients on, low risk. Their A is overall survival and B is disease-specific survival. So if we look at the case of Our Lady as an example, she was oral cavity, 55 years old, low grade, T2. So that gives her, 15 points or so. N0, M0, she did get surgery. So overall, she's very low risk. In terms of disease-specific survival, again, very similar. The only thing giving her points here is T stage, which still puts her at low risk. So you can tell her low risk, very high chances of survival at 3 and 5 years. So here's just a nice graphic presentation of some of the factors. We already talked about sex here. Here is that look at the differences in anatomic site. So you can see that oral cavity, and surprisingly in this group of patients from MSK, laryngeal and tracheal tumors also tended to do better, but the worst was sinonasal cavity. And then here you can see the difference that staging makes, no surprise here, and then low versus intermediate versus high risk pathologies. So what about cervical nodal metastases? Do we do a neck dissection on that lady? So overall, occult nodal metastases rates are low. So this was that study that looked at only mucoepidermal cancer in the oral cavity, oral pharynx, the one with over 12,000 patients. So they found that the significant variables were grade and then also clinical T stage. They only looked at oral cavity and oropharynx. They didn't find a difference between those two. But you can see that as the grade goes up, as the T stage goes up, the risk or the percentage, the rate of occult nodal metastases also goes up. But overall, it's still pretty low. We say our cutoff for doing elective neck dissection is you would tolerate up to 20%. So this is still under that, although it's, writing on 15. So you probably still would offer, again, high grade, high stage elective neck dissections. And then this is a paper looking at a prognostic index for just predicting cervical nodal metastases in general. So they identified 4 factors that in combination significantly increase the risk up to 6 times compared to patients without. So they found that pharyngeal subsite had a higher chance, probably because, of the proximity to the cervical nodes, and then also high grade adenoid cystic or mucoepidermoid male patients, as we kind of talked about, and then also higher T stage. So again, emphasizing grade and T stage there. So in her, she got adjuvant radiation, again, just to review, for adenoid cystic carcinoma, but no neck dissection was performed because she has, probably a low risk of occult nodal metastases given the low grade and low T stage. And then she did well with regular follow-up in clinic for 5 years. But then at 10 years, she presented with lung nodules with biopsies showing metastatic ACC. So the point that I wanted to make with that was that if we're looking at the patterns of recurrence, if you look at, N of 97 recurrence total, most of that number is going to be comprised of distant. And you can see here that, and we get taught this, adenoid cystic accounted for 69% of distant failures. So if we look at comparing, local regional recurrence-free survival versus distant is in green here. I mean, overall, the numbers are still pretty good, but distant is going to be where things recur if they do, especially with adenoid cystic carcinoma. So what about the data here at Cleveland Clinic? So we took a look at the tumor registry that we have from 2000 to 2022. There were a total of 205 patients with minor salivary gland cancer, and 55% were female, hitting right into that average. Median age was 59 years. And then if we look at the distribution of sites, very similar to what's been seen, mostly oral cavity, and actually here nasal cavity and paranasal sinus were second common. And then in terms of distribution of grade, most of the time we treated patients with low grade carcinoma, and then with it pretty much even split between intermediate and high. And then in terms of distribution of histologies, so very similar, although predominantly ours was adenoid cystic carcinoma at about a third of patients, and then sort of split between mucoepidermoid and then polymorphous adenocarcinoma versus adenocarcinoma not otherwise specified. But very similar that the 3 most common histologies were the same as all those big studies done previously. So for survival and recurrence, you can see that 5-year survival is roughly about 77% here for overall. For recurrence-free survival, local was 71, regional was 76, and distant was 71. And then we did also look at nodal disease and occult nodal metastases. So 28% of the patients underwent neck dissection. 40% of them had pathologically positive nodal disease, and 6 out of 35, or 17%, had occult nodal metastases. That's pretty similar to the rates that we saw on those previous studies. It was 14% for adenoid cystic and 30% for mucoepidermoid. And then you can see it was higher also for high grade. And then we had also looked at just clinically node negative cancers as well. So we had 143 patients with minor salivary gland tumors that were clinically node negative. 26 of them underwent neck dissection or nodal sampling. And again, a very similar rate of 15% occult nodal metastases. And if we look at the distribution of where those metastases occurred, so firstly, where did they do most patients which levels did they do neck dissection. Usually it was 1 through 3 were most common, as would be expected if it was presenting in the oral cavity. And then we only had, 4 out of 26 that presented with occult Mets, but it was predominantly in levels 1 and 2. So the strengths and limitations of, the work here is 205 is still pretty large, given that it's not a large nationwide database study. It's very similar to previously published data. The retrospective nature, it's not adding, new information necessarily to what's out there already. And I do think we were very interested in trying to predict occult nodal metastases, but I do think it's a little bit low for us to say anything definitively about it. The major takeaways, if you just had to remember a few things from this talk. So difficult to study because they're rare, they're heterogeneous, and they present at many subsites. Survival is influenced by grade, like we talked about, site, age, sex, and stage. And then occult nodal disease generally is not very common, but the things that would make you want to do elective neck dissection are higher grade and higher T stage. In terms of what we'd like to see in the future, so my work is still not finished on the research, but it would be nice to look at predictors of survival and recurrence within our data, see if it agrees with previous data. And there's still this question of how best is it to study these cancers? Is it better to look at both major and minor just by histology type? Is it better to look at just the anatomic site? Should we do more multi-institutional studies to get higher numbers so we can say something more meaningful about them? That's all I had.
Excellent job, Emily. Thank you, Dr. Zhang. We're very proud of the research that you did, and especially becoming like a content expert on that topic. I mean, you look like, you really know a lot about minor salivary glands now, including our own data. So can we open up for questions?
Emily, Eric Lamar here. Excellent talk. And as Dr. Koo mentioned, I think it's great to incorporate our own data within this. I think you did a nice job of depicting kind of the evolving landscape of salivary gland malignancies with respect to histologies. And I think along with that, you mentioned kind of the indications for radiation as well too. And I think that's also a moving target. So it's interesting, your case that you pointed out, even though they had 5 millimeters of 5-millimeter margin, and it was in the palate, which is, close to salivary gland, I'm sorry, close to the paranasal sinuses, and hard to get a good margin. That was a pretty good margin, but they still provided radiation to that. So I think as we evolve in terms of definitions of low grade, intermediate grade, and high grade, I think we're also seeing adjuvant radiation employed differently. And so we almost uniformly, for PLGAs, what was historically PLGAs, we provided a lot of radiation to that. So my point is I think you touched on a lot of this evolving controversies, and I think we'll probably shift in the way we give adjuvant radiation as well too. But nicely done.
Thank you. Yes, Dr. Kaminsky.
Given the distribution that you pointed out of salivary glands along the entire upper air digestive tract, I don't know why you have a salivary gland in your sinuses. Is there a difference in stage at diagnosis?
Yes.
Based on location?
Yes, there is.
You better repeat.
Oh, yeah, sorry. So the question was, given the distribution of minor salivary glands throughout all the different sites, are there different, do they present at different stages? And I think part of the reason why paranasal sinus tends to have, well, we think paranasal sinus tends to have lower survival is also because they tend to present at a higher stage because, it's less obvious something's growing in your sinus than in the oral cavity. So I don't know the specific numbers as to what percentage tend to present at higher stage, but I do remember reading that. Yes, Malek.
Thank you for an amazing talk with us. I was curious about the chemotherapeutic side of things.
Yeah.
Are there, because I know that adjuvant treatment in general for salivary carcinomas is sort of like, we're just throwing a can at it. Are there any good molecular targets that you know about, or things that are emerging, or is it just kind of like we use the same things that we do for squamous?
Yeah, that's a great question. And I can't say that I'm an expert on the chemotherapy side, but there
Can you repeat the question, Emily?
Oh, I'm sorry. So Malek's question was, can you talk more about the chemotherapy side of things? Are there new molecular targets? So I was reading a little bit about it. I don't know that much about the chemotherapy side, to be honest, but there are these studies coming out looking at specific gene translocations for different histologies and different different salivary gland tumors in general. And certain pathologies are associated with certain gene translocations or fusions. So they are saying that sometimes they can use FISH testing. Particularly, it's, I think, a little bit more relevant to diagnosis than treatment right now, because a lot of times what we're doing is doing an FNA on a parotid mass. We don't know, or it's, malignancy of uncertain potential. And then, looking for these gene translocations with FISH can be a way to try to get a better diagnosis before you go in and do surgery on them. So maybe a little less relevant for minor salivary gland carcinomas, but I do wonder if, targeted therapies for those are going in that direction.
Emily, Joe here. That was really an outstanding lecture. I really liked how careful you were with the results, giving confidence intervals on our results. Perhaps no other area will have as much change in it than salivary gland disease in general, as these targets are looked at, and everything in cancer will be driven by molecular targets. So several years ago, Dr. Lorenz and one of our former residents, Daniel Gaynor, found a sodium iodine transporter on adenoid cystic cancer, perhaps a target with radioactive iodine. I don't know if anything else has been done. Had you seen anything in the literature for the sodium iodine transporter and radioactive iodine for adenoid cystic cancer?
I have not seen that personally, no.
Yeah.
But I didn't also go into, each specific histology,
Mm-hmm.
but that would be interesting to look at.
Yeah, definitely. Great lecture. Thank you.
Thank you.
I have a question, Emily. So one of the surprising findings for me, at least, was the difference in terms of sex, in terms of overall survival outcome, as well as initial risk of nodal metastases that one of the studies found.
Mhm.
And I'm assuming that those are disease-specific overall survival, right? Whether it's from distant, recurrence, or local regional. But is there anything looking at the, the reasons for the difference, and that could be another pathway for some kind of new treatment.
Yeah.
And did our study also show the difference in terms of
I haven't
sex?
looked at splitting up the sub-analysis of the survival yet. So that's kind of next steps. I didn't see anything to explain the sex difference there. And I think that was for overall survival versus, and that has been seen in multiple studies, the sex difference, but I only saw that one paper that showed the odds ratio difference for cervical nodal metastases. So I don't know if that was specific to their patient group. But sex I did see multiple times. I didn't see anything about, reasoning, but that could be a potential. Maybe there's hormonal impact. The focus of this talk was not on free flap reconstruction. So, it wasn't a very realistic case. I just used it to, present things that I wanted to talk about. Realistically, she probably got a free flap. Yeah. Realistically, it was probably high grade, and yeah, she got a free flap.
Well, and the one thing to know, with adenoid cystic, they do have a lot of perineural invasion. So
Right.
that's probably another reason why they got adjuvant radiation.
Right.
Excellent. Any other questions? So thank you, Dr. Zhang, for being our first resident to present at Head and Neck Live, and we're very, you gave an amazing talk and you set the standard very high for the rest of the residents to come. So,
Thank you.
and it's 7:40, so hope everybody has a great Wednesday. Hump day.
Thank you.
See you guys.